kick off this afternoon's session of exceptional learning and patient stories, no doubt, we have Professor Kelsey Hegarty, who specializes in family violence prevention at the University of Melbourne and the Royal Women's Hospital. Prof. Hegarty is also a member of the Open Strategic Committee, so please give her a warm welcome.
Hello, everyone. It's lovely to be here, and I really thank Joanne Mansky-Nankervis and Eileen for inviting me. I begin all talks by acknowledging the strength and resilience in the room of people who've had adversity and trauma. And some people have always asked me why, as a GP, I'm researching domestic, family and sexual violence, and I say, it's the leading contributor to death and disability for childbearing women. And I think that it's not a topic I understand that Singapore has researched a great deal, but when I'm talking about the survivor advocates, as we go through, you can change the word survivor to patient advocate if you like. But I think that for me, the language matters. And Emily, I'm with you. Experts by experience is the term that we use in Australia, because in some ways I think patient has a power imbalance just by the nature of using the word. So I'd like to acknowledge my fellow colleagues on this, Lily Fetter and Katie Lamb. And I'm going to be talking about the Weavers. So they're a group of women with lived experience of domestic, family or sexual violence. And we started in 2016 with about 9 women, and we're now up to 36. And they work with us at the Safer Families Centre. And the Weavers called themselves the Weavers, and they weave lived experience into the research that we do. This talks about research, not healthcare, okay? So we're mainly talking about how to weave lived experience, experts by experience, into research. And I'm really don't try and talk for the Weavers. So this is a video of that was done during COVID. So it's not a high-tech video, as I said yesterday. I showed it yesterday in the workshop, but they did it all on Zoom or at home or took photos, and someone narrated it from Weavers. So I'll start it.
Experts by Experience framework. In our own words, addressing power and control imbalances when working with people with lived experience of family violence and domestic abuse. Victim survivors of DV and trauma come from diverse cultural backgrounds. So if you don't know, please ask someone else of that background. Get a fuller picture. By you being better informed, it helps victim survivors to open up and to give themselves better control over their reactions. Please make sure we're aware of the right dress code for the setting so people take us seriously, which is hard to do if I've rocked up in my activewear and it's a bank in the city. It's awkward when the survivors are the only ones in the room getting the handwritten stick-on name tags. Please don't leave it up to us to ask you if we'll be paid for the work we'll be doing. We're survivors of trauma and abuse, but we are much more. We're someone's mother, grandmother, daughter, sister, friend, spouse, co-worker, business partner. We are professionals, teachers, students, carers, complex human beings with dreams and potential to be much more. A traumatised person or a survivor you see before you is just a snapshot of our lives, not the whole person. Sander. Let us make decisions, and where we disagree, let us explain all our perspectives to contribute and vote on it ourselves. Give us as much decision-making agency as possible, but also be honest and transparent with us about the realistic limits of this. Please take the time to build trust and develop this within the group and with the staff involved. Anonymous. Just because I'm quiet doesn't mean I have nothing to say. I may not have the years of family violence training you do. I may not have a PhD, but I have lived it. I have survived it. I don't want to be viewed as someone who is damaged or traumatised. I want to be viewed as someone who has something of value and importance to contribute. Jasmine. To support me in my ongoing role, my emergency plan is in my records with my local hospital, doctor, and with my psychologist. Take the time to read it. Speak to my professionals. Get a bigger picture. I give you permission. Everyone else is introduced as Professor this or Doctor that. Find out how each survivor would like to be introduced. Do they prefer survivor, victim survivor, advocate, expert by experience, or something else? Personally, I prefer advocate. Avoid using jargon and acronyms so that everyone's on the same page. Survivors get talked about, talked to, talked at, or talked over. I think it is very important, if you ask for our knowledge, expertise, or experiences, to actually listen to us. As survivors of family violence and abuse, we need to be supported to be the writers, the creators, the directors, and the producers of our own stories in our lived experience work. We need to be involved in setting the agenda and the design process from the start. There should be nothing about us without us. Anonymous. Our sincere thanks to all the women who contributed their words, names, and/or images to this video. For safety and privacy reasons, some women chose to contribute anonymously.
So you can hear resonating words, can't you, over and over again. And I think that I came to this as a GP, a family doctor, and a researcher, where I did cluster randomised controlled trials and got published in big poobah, things like the Lancet. And then I moved on to really looking deeply at voices of people through qualitative work. And now, I obviously work a lot with practitioners. So we've got the traditional evidence base, we've got practitioner wisdom, and now we have experts by experience. And I see it as we need to dial that up. We can't forget the other two, because that would be bad. But that sort of grouping, we need to have all of it, I think, because some people are changed by the numbers and some people are changed by the stories, and some people, we need to, really work together on those things. And the Weavers do a whole range of things, and they really have co-designed best practice standards for ethical engagement. And I think that's really why I was asked to come. But they do set up their own research projects, they facilitate workshops, they conduct focus groups and interviews. We've trained them to do that. And they are teaching and training medical students as well. This is them at an international conference. And I would say all these women had trouble actually even talking out loud in the first meeting we had. And 3 or 4 years later, they were giving a whole conference presentation. So when we're talking about empowerment, it was certainly very striking. And it's the happiest thing that I do is work with them. And we've made one for the family violence sector, or, you could look at it as the health sector, but we also had a small amount of World Health Organization money to do the Australian framework, and I'll tell you where you can look at that. Oh, it's down the bottom, the Safer Families, but I'll show you again later. And I don't think I need to define co-design research. It's really, you're doing it with people. You're not just consulting people. And we've had lovely examples earlier today around this, and it's a different way of doing it. And in Australia, they've been doing it across all sorts of areas. Mostly our First Nations or Aboriginal communities have been doing it forever. It's the same as in Canada, isn't it, Antoine? They really know how to do participatory action research involving communities, but it's in a range of areas. And in the cancer area, they've done a nice model. I know you can't read that, but it's certainly something you could go and look, which is the CCC alliance.org.au. But I think, you know, and I think people today have outlined this difference where traditional researchers make decisions rather than in partnership. I think this is something worth discussing this, you know, maybe later, seeing marginalised people as vulnerable or resilient and capable. And I think we really need to fix that. And obviously in Australia, we've got a colonising, heteronormative and ableist type in the traditional research, whereas co-design involves everybody. So you can't have that. And the speed that we've talked about as already. Now, it's not exactly a continuum like this, but when I ran the workshop yesterday, it seemed that most people were on the patients were participating or advising. Obviously, we're collaborating in this room, but the end of it where patients are actually working on the project after funding or actually setting the agenda for what the grant could be, the co-design, co-create area, it's less common, it seemed, in the people I talked to yesterday. And one of the things we didn't do at the beginning, but which I think I wished we'd done earlier, was really get these key principles in place. And I think that that's an important thing. And I'm going to go through them. You may not be able to read some of the text for each of them, but I think it will help us think about whether that's something Open Voices wants to do more work on. So agency is this idea of empowering patients to self-reflect whether they want to participate or not. And we went through some self-reflection questions. And I feel really strongly that we shouldn't be choosing who comes in as co-design teams or research teams. The transparency about what's required and how much reach and degree of influence you can have. We have to be patient-centred in the way that we go about our business. We have to have safety and support. And Emily, great that you were talking about psychological support, because I think it's really important. Obviously with survivors, it's really important, but with everybody, you know, just really making sure that people have got supports. And then accountability about complaints mechanisms and so putting some structure around these ways of working with experts by experience. And we spent quite a bit of time yesterday talking about researcher preparedness, and these are all on the website, so people can go to the website. You know, we're not really trained to work in this way. We're not even trained. I'm a medical graduate. I'm not trained to work in a team. Of the doctors in the room, who's been trained to work as a team? It's you know, some of us do it more naturally than others. But mutual exchange where everyone's learning from each other. As I said, I've learnt a lot from the Weavers. And recognising and value. We've touched on the issue of paid. We now do not do anything unless someone is paid. And that sometimes means we don't do something because we don't have the funding. But I think it's a fundamental right that everybody in the room should be paid. And relationships we've heard a lot about, and inclusion of diversity. And I think yesterday we voted for relationships and mutual exchange as being maybe the first steps. And Open Voices has that in spades. I can see that already in the time that I've been here. How are you going with my Australian accent? Yeah, okay? Okay, you're pretty used to Australians, okay. And then we talked about this in the workshop yesterday as well, you know, and we did it a bit before. Who's been a patient? Who's been a carer? Who's an academic? Who, you know, and in the mental health area in particular, almost all of us have had some mental health issues or distress or something. But in Australia, there are designated lived experience researchers who are specifically employed for that. And we're doing that in the survivor area as well. So, you know, they have said, I am being employed with my experts by experience, as well as they may have research qualifications or they may not. And I think getting this clear is worthwhile in the process that you're doing. And human research ethics are really not very good at doing this because, you know, they always want everybody to have ethics training and they want everybody to have some sort of track record or something. The grants are the same. So we really have to train our ethics boards to see patients or survivors as research participants. And no, sorry, not as research participants, but as part of the research team. So in the last little bit I've got, I'm really going to share thoughts about what we have learnt from the Weavers. As I said, I'm not talking on behalf of them. These are things that they tell me. And I can see it's a bit of a dilemma here because we don't ask the survivors to share their stories anymore. Some of them can volunteer to do that in media or in other areas, but that's not, they're not bringing their experts by experience to tell their story. And we say you don't have to. They really are there to inform from their life experience. And if they happen to tell us a little bit about themselves, the same as I would tell you, then that's great. Payments, I've talked about that. So we really need to be getting the infrastructure is in holding and supporting advocates administratively, emotionally and logistically. And if we haven't got that in place, I think, you know, and you have here to some extent. So I think we need to, you know, make sure that we have those things. And the bit about power dynamics, I think, Emily, you could have given my speech for me, really, because, you know, this idea of how can we make everybody feel equal and equitable in a room, and the long-term meaningful relationships. And so the Weavers see the following issues as key considerations: importance of agency, autonomy and choice about participating, researchers getting better ready to do this work and to share their power, focusing on benefits as much as risks, and transparency. So, you know, it's an exercise to go through the principles and actually apply them to your context. And questions to leave you with are, where can you engage patients? And how can I engage them in a way that draws on their expertise, not just their story? And how can it be sustained over time? That's really the main messages from this. And finishing with Weavers' voices as well. I found it affirming and empowering to have my voice heard and to use my experience to help others. I felt that at least all the trauma I went through could be used to help others, and that made it more bearable. We don't want to be just wheeled out to tell our stories when it's convenient. Agency must be given to survivors to empower and enable a dignified restoration of broken lives. And the framework is on our website, saferfamilies.org.au, and in that framework, there are a co-designed decision-making tool, the self-reflection questions. We've got a project commencement, I'm going to show you that in a minute, and some examples in practice. And I find this quite useful to think about the degree of influence and resourcing that the different activities that patient, you know, advocates might be involved with. I use this as a tool. And this is like before the project commences, at the first project meeting, there's further on, just really stepping people out so that there's a structure to what you're doing. And this is just to show you that some of the survivors have been co-authors on papers. We've evaluated, working with the Weavers, we've evaluated you know, what they think about being involved, and they see themselves as making a difference, having that collective experience. And there wasn't a really clear blueprint when we first started. So this is the website. We've got a heading that says lived experience. If you go into that, there's all those things that I've just talked about. So thank you.